Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. The older population is growing in the U.S., and West Virginia ranks third in the nation with more than 21% of its population aged 65 or older. Chances are you fall in this category or are looking after a parent or loved one who falls in this category. As we age, there's increased potential for illness, falls, and multiple health issues. If you're an older adult, you probably have one or more long-term health issue, such as arthritis, heart disease, or memory issues that a geriatrician should treat. When should you see a geriatrician? How do you best maintain your quality of life and independence as you age? We'll answer those questions and more as we're talking about geriatric and palliative medicine with Dr. Osvaldo Navia, Division Chief of Geriatrics, Palliative Medicine, and Hospice at WVU Medicine. Welcome, Dr. Navia, to Live Healthy West Virginia.
Thank you, Mary. Thank you for the invite.
Well, it's great to have you here. So let's just get started with the basics here. What is geriatric medicine and what do geriatric medicine doctors do?
Definitely. Geriatric medicine is a medical specialty that the most important thing for us is to improve the quality of life of our patients and also to concentrate in patient-centered care. That's our main goal. Geriatricians, after finishing a residency in internal medicine or family medicine, they pursue that fellowship 1 or 2 years in order to get further skills in terms of taking care of people more than 65 years old or our older population. Geriatricians are being trained in order to treat, identify quite specific medical problems in people more than 65. And you have to understand that illness, medications, behave in different ways. There is some difference between what happens with older people in relationship with younger population. At the same time, people more than 65, they are taking multiple medications, and also there is some kind of overlap of medical problems. Geriatricians, they have the skill in order to identify the best way to treat our patients. Discuss about the risks and benefits, and the most important thing is to advise about the proper steps in order to improve your health in general.
Okay, so why should a person go and see a geriatrician?
One of the greatest examples they have is if you are a pediatrician, for instance, you are being trained in order to see children. Same thing happened with geriatricians. They're being trained to treat older people. There is always a question about when I'm going to switch my care or when I'm going to add my care, a geriatrician to my care. I like to think in this way. If I want to optimize my health, and I'm probably more than 65 years old, probably I'm going to see a geriatrician. He's going to give me a good advice in terms of my health. Or even if I'm not performing as I used to do when I was a younger person, probably it's the time just to look for additional help and also advice in order to improve my quality of life.
So around 65 is when you should see a geriatrician, but can you still see your PCP? Can you see both a geriatrician and your PCP, or should you transfer over to a geriatrician?
That's an excellent question. There is no specific age when you're going to see a geriatrician. But we're thinking that if you reach more than 65, probably it's a good idea to get help for somebody who has extra training in the care of very complex medical issues. And the answer to your question is if a geriatrician or PCP, I will say both. Because a geriatrician is quite a specialized care that they're going to probably assess the patient and give an advice for your primary care physician in order to improve your health. But at the same time, geriatricians could be primary care physicians if it's your wish. That somebody is looking for quite a specific care and have this kind of close relationship with somebody who has this extra training, probably would be a great idea to be a primary care physician as well.
Okay, good to know. So, what are the most common conditions geriatric doctors treat?
Multiple of them. For instance, we focus our attention in chronic problems.
Okay.
Heart, lungs. But we have some kind of quite interesting inclination to see patients with memory problems.
Oh, yeah.
Patients that they have problems with coordination and multiple falls. Polypharmacy, patients taking so many medications that many times we need to reassess if they're really needed. Patients that they have depression, anxiety, patients that probably are going through questions about goals of care. We really like to talk and sit with patients and families about what are going to be the next steps in terms of their care.
Okay, so you mentioned polypharmacy, and that's help with medications. I mean, is it common that older people may be on medications that can conflict and cause problems, or medications they just don't need to be on anymore?
That's correct. Many people is asking, what is the definition of polypharmacy?
Yeah.
I mean, there is now a real agreement about this one, but we are thinking that 5 or more medications could be called polypharmacy. The question is if these medications are working together or there's some kind of contraindications or probably adverse reactions creating for these multiple medications for patients. And this is our role. We like to review the medication list, talk about risk and benefits. We have some patients taking benzodiazepines, opioids, high anticholinergic burden medications, and we like to talk to the patients and families about the risk and benefits. One of the things that we really like to do is de-prescription. We de-prescribe medication, meaning that we decrease the amount of medication that you are taking according to the needs of the patient.
Oh, okay. So de-prescribe, lessen it. Correct?
That's correct.
Wow. Okay. Now, falls are certainly common, you know, as we get older. Do you offer like prevention and treatment of falls, both?
It's a quite interesting question as well. Every second, we have an older person falling.
I totally believe that. I do.
And unfortunately, 1 out of 4 older people are going to have a fall every year.
Wow.
Meaning that is one of the high risk factors for injuries and death-related injuries for people more than 65 as well. How we're going to do in order to prevent falls probably will be the first part of your question is talk to your clinician. If you are feeling that you're having a lot of falls or you're feeling insecure when you are walking, probably is the time that you need to talk to your primary care physician. Review your medications. We already talked about polypharmacy. One of the main reasons for having falls is because you're taking so many medications and probably you're going to feel dizzy, you're going to feel confused. Every time that you're changing positions from sitting to standing and you're feeling dizzy, this is the time for your clinician to do a re-evaluation about what's going on with you. It's very important to talk to your clinician if you're feeling that, hey, I'm not secure walking or I'm feeling quite dizzy every time I'm changing positions. The second thing I will say is keep active. Continue doing exercise. Tai Chi, for instance, is a good way in order to get strong legs and also to improve your balance.
Your balance.
The other advice that we probably are going to talk to our patients is keep safe at home. Lighting, having something like handrails, something like to have some kind of support when you're taking a shower. That's the best way to prevent falls.
Yeah.
At Ruby Memorial Hospital, we provide consult service for trauma patients.
Okay.
People more than 65, they're going to have a falls. They have something like assessment, a comprehensive geriatric assessment performed by Geriatrics.
Okay.
At the same time, when you're going to be discharged, we have a geri-trauma clinic, meaning that we are going to complete different testing, education for patients and families in order to prevent further falls. Probably in a couple of months, we are going to have another clinic, which is going to be PMR Geriatric Clinic. The kind of clinic is going to be for prevent falls, for people with high fall risk that probably need to be reassessed. We are trying just to close the loop, having an assessment before having the fall. If you have a fall in the hospital, we have a consult service, and then we can just continue with our geri-trauma clinic as well.
It kind of sounds like when it comes to falls, it's not a matter of if, but when. With I think many more people than realize.
Yes, I agree in that sense. That's why the main task that we have as geriatricians is to prevent falls. And let's talk about different kind of risk factors. And the most important thing is to find a solution. Unfortunately, having a fall is multifactorial.
Yeah.
It's not just one thing that is going to cure everything or going to find a solution for everything. But we like to just explore different kind of options with patients and families.
So what would your advice be for adult children that are worried about their elderly parents and how to get help for them?
There's a couple of things that I would like to advise when you have your parents at home, for instance. One of the things that I really advise is clear communication. It's very important to listen to your parents. Mm-hmm. It's very important to understand their point of views. Respect. If you show respect about what they're trying to tell you and taking seriously what they're trying to tell you, probably is going to improve the communication and you're going to help your parents better. The other thing I will say probably is the sense of control.
Yeah, that's a big one.
Older people really like to be independent, right? And if you are going to provide some kind of options, alternatives, and giving some kind of control about their lives, there's a big studies that are showing that improves the well-being for these patients. The other thing that is very important is be positive, right? Let's concentrate in positive aspects of aging instead of the negative aspects. And I think that's going to improve your quality of life as well.
Excellent. Good advice. Good advice. So it's my understanding there is, we've been talking about geriatricians. There's a nationwide shortage of geriatricians. So how are we dealing with that here in West Virginia? Because I'm sure there's a shortage here if there's a shortage nationwide.
That's correct. Unfortunately, statistics is telling us that probably we have around 7,500 geriatricians in the whole nation. If we are going to put this number in context, it's just 1% of the all U.S. physicians. The other thing is by 2030, probably,
not too
2030,
we
are going to have, people more than 65 is going to be 20% of our population.
Wow.
Meaning that probably we need something like 30,000 extra geriatricians in order to take care of our population. This is a big gap between how the population is growing and the shortage of geriatricians, the shrinking of geriatricians in our nation. I'm working at West Virginia University in the last probably 6 years.
Okay.
When I arrived here, we didn't have geriatrics in the Department of Internal Medicine.
Oh.
But we are working very hard. Right now we have something like 4 geriatricians.
Okay.
We are providing services in the inpatient service, outpatient service. We are going to nursing homes as well. And also we are training geriatricians. We organize a fellowship, meaning that we need to train our own people in order to take care of our population. I think that's a vision that was shared by Dr. Sarwari at the beginning. That was the chair of medicine. And now Dr. Lerfeld is quite active in terms of growing our presence in the inpatient, outpatient service and nursing homes as well. So the other approach that we have is to train residents and fellows from different specialties and just to provide specific point of views in terms of geriatric care. And we're expecting that they're going to disseminate the philosophy of geriatrics, and we are going to improve the care of people more than 65 in our state.
Okay. Well, if we're talking about the older population, I feel like we need to talk about palliative medicine. So what is palliative medicine?
Palliative medicine is a medical specialty as well that is probably focused on provide the highest quality of care and also increase the comfort for patients that are really, really sick.
Okay.
This approach has been done as something like interdisciplinary team. We have physicians, nurses, chaplains, social workers who take care of these patients. Palliative medicine can be provided regardless of the stage of your disease. You can have palliative medicine care even if you are taking chemotherapy or radiation therapy.
Okay.
We are providing something like an extra layer of support for patients really sick.
Make them as comfortable as possible or pain-free as possible, or?
It's something like different aspects. One of them is we have a quite aggressive care of symptoms, including pain.
Okay.
We like to discuss about the goals of care, including advanced directives for these patients. We really like to know about what are the values of the patient. We need to know what are expectations, what's the most important thing for these patients in order to tailor our advice and the care of them.
All right, you just mentioned advanced directives. Can you just make that clear for us on what exactly an advanced directive is?
Definitely. Advanced directives are written legal documents that probably is helping clinicians to understand what medical procedures are acceptable for the patient in case they are not able to make decisions by themselves.
Okay.
We are talking about a medical power of attorney, meaning that the patient can name who is going to be able to make decisions for these patients in case that he's not going to be able to do it by himself or herself.
Yeah.
It's very important to have a medical power of attorney because we cannot probably cover all the different clinical situations that you can encounter, and we need somebody who knows your values, who knows your goals of care in order to help clinicians in order to make decisions in your medical care.
And ideally, I imagine you want to choose a medical power of attorney long before you reach the stage where you can't make decisions for yourself. It kind of takes some pre-planning. Not that you can't do it later on, right?
Yes, definitely. That's the ideal situation, right?
Yeah,
when you have
right.
something like the opportunity to think about it and try to just communicate. Many times it's going to be your family member, your medical power of attorney. This is the time that you can just do this one, and instead of just making these decisions or having somebody else making these decisions for you. In terms of advanced directives, I'm going to talk also about the living will.
Yes.
It's another
now, what is a living will? Tell us that.
It's again, that's a written legal document that probably is telling clinicians what is acceptable or not to keep you alive. For instance, you can just spell out what are going to be the interventions that are going to be acceptable for you. Let's say something like chest compressions, a breathing tube, feeding tube, going back to the hospital, medications. It's extremely helpful in order to understand what are going to be the way that we need to proceed in case that you are going to be quite sick.
What you want and what you don't want to be done.
That's correct.
Okay. Do you need to have an advance directive to have a DNR, a do not resuscitate order?
Not necessary. I mean, you can have a DNR order, do not resuscitate order, or DNI order, do not intubate order, even without having a living will or medical power of attorney. You can just talk to your clinician. So your clinician is going to just document in your records that this is your wishes. Okay.
Good to know. Let's talk a little bit about the POLST. What is a POLST? A POLST. That's what. Tell us what that is, and can that replace an advance directive?
Definitely. The POLST is a physician order for life-sustaining treatment. It's in our state, it's a pink form. It's just a simple page. that it doesn't replace a living will. It's something like probably can complete. It's an addition to to any advanced directives. The good thing about the pulse form is you can take this one with you. It's a physician order that can help clinicians in case of an emergency, just to understand what are going to be your wishes in terms of, again, chest compressions, breathing tube, feeding tube. If you want to go back to the hospital, is a quite interesting document and extremely helpful for people who are quite sick in order to understand what is your goals of care.
Okay. So it really spells out what you want and what you don't want.
That's correct. And the good thing is complement to your living will, complement to any kind of advanced directive. Doesn't replace them, but can just be quite specific about what are going to be your goals of care.
Enhance it.
That's correct.
Okay, good to know. All right. So we've been talking about palliative medicine, but what exactly then is the difference between palliative care and hospice care?
Excellent question, because many people have some kind of problems in order to understand this one.
Yeah, they sound similar. They do.
Definitely. As already mentioned, palliative medicine is something like a medical specialty that provides extra support for people that are really sick. They are probably able to help with symptom management. They can discuss advanced directives as well. You can have palliative medicine at any stage of your disease. And even if you are under palliative medicine care, you can continue having active treatment, something like chemotherapy, radiation, meaning that's something that's going to go with you, and there is no limitations about palliative medicine. Hospice is something like probably is going to be, again, we're going to focus on high quality of care for patients that probably they don't have cure for their diseases. It's for somebody who may have something like 6 months of life left. Patients that probably medications are causing more adverse reactions than benefits. Patients that are really, really sick. This is the main component of palliative medicine. And again, they have something like an interdisciplinary team approach. They have physicians, nurses, for people that probably they're going to have 6 months or less of life.
I think hospice has changed over the years. I think there's a lot of misconception out there that many people think hospice, that's for like the last few days or the last couple of weeks of life. But it's really, like you mentioned, 6 months or maybe even more.
That's right. I mean, it's something like it's going to be reassessed, because it's something like we have an idea as a physicians that probably are going to live just, less than 6 months, but it's not the case. Many times you are living more. As long as you are thinking as a clinician that this patient is going to live less than 6 months, probably you're going to qualify under hospice care. But again, hospice care is another layer of support for people that are really, really sick.
Okay. So before we go here, I always like to ask, what's the most important thing you want our viewers and listeners to know about geriatric medicine and palliative medicine?
Geriatric medicine is the care for older people, specialized care for people, for older people, that they have clinicians that are highly trained and understand all the medical problems, complications, expectations for patients and families. They like to communicate, not just with the patient, with families as well, because it's really important, this kind of approach for the care of people more than 65 years old. We have different kind of options here in Morgantown. We have a clinic at UTC, University Town Center. We have another clinic, and we are part of Rockefeller Neuroscience Institute for a memory clinic. We provide consults at Ruby Memorial Hospital as well. We go to different nursing homes, meaning that if you are looking for this specialized care, there are options, and we really love to take care of people more than 65. In terms of palliative medicine, just remember, if you are really sick, you have something like very advanced medical problems, this is the kind of clinicians that are going to help you to control any kind of symptoms. This is the kind of clinicians that are going to talk and sit with you and talk about quite complex goals of care. It's somebody who can just communicate properly any kind of, I will say something like prognostication. They're going to tell you what is going to happen in the future. They're going to be able to listen, assess your values, assess your goals. Mm-hmm. We have different palliative clinics in the main institutes in our system. We have something like an onco-palliative in the oncology department. We have neuropalliative at Rockefeller Neuroscience. We have NSTCHF in the Cardiovascular Institute. We have population health palliative, meaning that we have multiple clinics, and we are really happy to talk about goals of care. And the most important thing, just to control any kind of symptoms, including pain, that you may have when you are really, really sick.
Good to know. That's a really big umbrella, too, of services.
Oh, definitely. Yeah. And remember, geriatrics and palliative medicine just overlap so many diseases, and we're seeing at the end patients that probably are going to be older population and probably they're extremely sick, and I think this kind of coordination is extremely helpful for these patients.
All right. Well, good information and good to know. Thank you so much for sharing this with us. I know we covered a lot of ground, but I know a lot of people will be helped by this information. Thank you.
Again, thank you. Thank you, Mary. Thank you for the invite.
Good to have you. So that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about geriatric care, visit wvumedicine.org/geriatrics. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast. I'm Mary Ravazio Menard, and on behalf of Dr. Navia and everyone at WVU Medicine, thanks for joining us.